Everyone, welcome. We are just is being recorded. We're just starting the recording. Really happy to have everyone here again today. This is, as many, if not all of you know, a preview essentially of the Aspen Ethical Leadership Program, which will take place this year in person on September 11th through 14th up in Aspen, Colorado. And the intent of these programs, which previously have been limited to those who are already accepted to and registered into the program. But the intent of these sort of meet the keynote conversations is to try and mimic the sort of informal opportunities that we try to create at the program to meet and chat with speakers and learn more about them as human beings, in addition to what they have to teach us in their roles as health system leaders. The Aspen program, and by the way, we've opened this one up, this Meet the Keynote up to a much larger audience, in part because of the salience right now of the issues that we're going to be focusing in on the second day of the Aspen program. The program in general attracts people who are often in senior leadership, people who've been involved in leadership long enough to have come to realize that health system leaders experience moral dilemmas, and they don't get a lot of opportunity for support in working through those dilemmas together. We spend more time, I think, talking about clinical ethics dilemmas and more time talking about the dilemmas that are faced by the sort of day-to-day practitioners, and less time focusing on the moral aspect of being a leader in a health system. And so that's what we focus on in the Aspen program. It will take place this year, as I said, live. We have 3 keynote speakers, one of whom is joining us today. The other 2, just for background information, are Dr. Bashara Shukair, who is Senior Vice President and Chief Health Officer at Kaiser Permanente, and has been the Biden administration's vaccine czar. We'll be talking about issues of equity on day 1 of the program. And on day 3 of the program, we have Dr. Lisa Lehman joining us to lead off a day of conversation on future tech and data ethics. Dr. Lehman is the Director of Bioethics at Google. We're also, by the way, planning a very interesting and I think will be quite provocative political conversation with several politicians from Colorado, talking about how the pandemic has affected the political climate moving forward. Malia is the doer of all things magical on this program today, so she'll be dropping registration and application information into the chat as we go along. In the meantime, let me just introduce our speakers for today. While I'm pulling that up, I'm going to thank the funders and sponsors of the program, which include Copic Colorado, which is our local physicians insurance company, and Delta Dental of Colorado. So now let me introduce our 2 conversationalists today. Dr. Wendy Dean has practiced for 15 years as first an emergency room physician and then as a psychiatrist, but she left clinical medicine when she found the priority of revenue generation was crowding out patient-centered care. And since that time, her focus has really been on finding creative ways to make experiences in the healthcare system better for both patients and clinicians. She works on innovations in technology, but also innovations in ethics and in health systems. She's served in a variety of leadership positions over the last decade, including overseeing medical research funding for the U.S. Army and in the nonprofit sector. And in 2019, little did she know, just before the pandemic, she turned her attention full-time to the issue of addressing moral injury in healthcare. She is a regular contributor to Medscape's Business of Medicine. She blogs for Psychology Today, and she continues to do work with NASA, with the American Society of Reconstructive Transplantation, and she works with the Transplant Ethics and Policy Group at NYU's Langone Medical Center. She will be our opening speaker on day 2 of the Aspen program, and really will help us to frame our work together that day on how to ensure lessons learned about moral injury during the pandemic are used by health system leaders to improve healthcare into the future. And in conversation with Dr. Dean today will be Dr. Ira Bedzo. Ira is co-founder of the Aspen Ethical Leadership Program. He's a senior fellow at the Center for the Study of Law and Religion at Emory University, and he's head of the International Chair in Bioethics Unit at Emory, which is a World Medical Association cooperation center. He's also senior scholar of the Aspen Center for Social Values. He co-directs the Maimonides Institute for Medicine, Ethics, and the Holocaust. And he's a regular contributor at Forbes for their diversity, equity, and inclusion section. And I will turn the conversation over to Ira.
Thanks, Matt. And also thank you, Wendy, for agreeing to have this conversation with me today. I'm selfishly really excited about it. We've had many opportunities to talk about moral injury and almost, I would say, everything under the sun. But now we get to focus on not only you, but how you and your thought has developed and how your experiences shape the way you think about moral injury, both in the present and what we can do about it in the future. So I'm really very much looking forward to hearing about you, your life, and what you have to say.
Well, thank you, Ira. I'm excited for the conversation. We've talked about a lot, you're right, but not a whole lot about the background. So looking forward to it.
Yeah. Well, then let's just jump right into it. We'll start at the beginning professionally, not like when and where you were born. But one of the things that I noticed about your professional background is you started as a surgeon and then became a psychiatrist, which is interesting in and of itself, and also I find really interesting in terms of how that might impact how you think about healthcare. Seeing those specialties are so different. So how did that happen, and what has that done for you?
Yeah, I think it's confused me. No, seriously, I think I went into surgery because it really is sort of how my mind works. I'm a very I want things to happen now. I want to fix things now. But what I realized was that the way that we practice surgery didn't necessarily, or at least in my training program, didn't leave a lot of room for the humanistic side, like human side of medicine. And I couldn't imagine going through my entire career putting that aside. So I ended up stepping off the track. I actually thought I was going to leave medicine altogether. And I stepped aside. Before I did that, I thought, well, let me go and work in a place where I'll see everything. And so I actually went and worked as an ER doc in rural, like far rural northern Vermont and New Hampshire for a couple of years. And I figured that was a place where I would see everything under the sun in medicine, and it would give me a good idea of what I was interested in. And it turns out that the patients coming in a psychiatric crisis were the ones that I found most intriguing. And psychiatry was a big black box still. And so I thought it would be hard for me to get bored in psychiatry because so much new was being learned. And also because human behavior just fascinates me. So that's how I ended up going into psychiatry. But the interesting thing that I found about practicing in those two fields was that the challenges each side faced were really not that different. So when I was a surgeon, it was the operating room that was driving a lot of the decisions. But in psychiatry, I was struggling to take care of my patients because of the constraints from insurance. So although the pressures were coming from different places, the end result was my patients weren't getting the kind of care that I felt like they deserved.
You said something I just want to ask or pick up on. I mean, you said that you left surgery because there wasn't, you didn't find that there was room for like the humanistic side in medicine. So you wanted to first you wanted to see what was out there, and you wanted to go into psychiatry. So it was interesting. do you think that there are just certain specialties that don't have the ability to see the humanistic side of medicine, or do you think that was just your experience due to organizational or structural constraints in surgery of where you were?
So I think it's I don't think it's a specialty. I don't think it's a specialty based problem. I think, or a challenge. I think that in fact, there are a lot of surgeons out there. And in fact, my business partner is a plastic surgeon who is very psychologically astute and is very attuned to the human side of patient care. I think where folks are struggling more these days, especially, is where the productivity constraints or expectations start to impinge on practice, where you're being asked to see 6, 8, 10, 12 patients an hour in clinic. And you know that's not sufficient. But those are the expectations to maintain revenue. So I don't know, I don't think that this is it's not a specialty driven piece. It's an organizational, maybe a financial driver. Yeah, but I think it varies. I think it varies from location to location. It's also a culture issue.
And if I remember correctly, and just correct me if I'm wrong on this, but at one point you left practicing and you went into research or technology, and then eventually worked for the Henry M. Jackson Foundation. Like, why? What was that decision? Why did you go from specialty to then out of clinical practice and then now back into examining how clinical practice can be improved? Like, what was happening there that made you think about those types of decisions?
So as I went from surgery to the ER to psychiatry, I kept trying to find ways that I could find a practice that would allow me to take good care of my patients and be sustainable for me. And for various reasons in each of those different types of practice, one side or the other was suffering. And so I went out into research funding oversight with the Army, with the US Army, mostly because I wanted to think about taking care of patients from a different perspective. How do we innovate in healthcare? How do we develop new technologies, new devices, new approaches to healthcare so that maybe we can provide better care in a way that's easier for clinicians, or at least more efficient, more effective? And I found that really fascinating. But at some point, I started thinking even bigger, which is when I moved into the executive position, to think not just about regenerative medicine and hand and face transplants, but to think about infectious disease and emergency management and all of those bigger picture questions. So each time it was trying to find a new way to approach patient care. But it also gave me the opportunity to see physicians, how they practiced across a wide variety of practice models. So for example, in very small private practices versus huge academic practices. And it allowed me to see who was really struggling, even though they were at the tops of their fields, and who was doing relatively better.
Did you see a difference when you worked for the Army in terms of, I can imagine military medicine being much more constrained than civilian medicine, having a lot more external factors to consider? Because not only are they practicing medicine, but they're within a military structure that's just different than civilian life. So did you see something there that was, I can learn from this because it's just that much quantitatively more, or was it were there certain things that were just disanalogous? It, works for the military or doesn't work for the military, but you can't apply generally?
Yeah, so I think the really interesting thing about military medicine is that the healthcare revolves around the soldier who is out walking point. So the reason that they have physicians is to make sure that that soldier is battle ready. And I think what that does is that it heavily resources medical care. It smooths away a lot of the barriers that are in civilian care because there's a different goal to it. There's a different point. And so what it allowed me to do was to compare what does it look like when healthcare has a lot of those barriers removed. If a soldier is unwell or injured, there are vast resources applied to improving their care, improving their state. In civilian life, that's not always the case because we're more concerned about there are finite limits to the resources that we have available. So how do we pick and choose? How do we narrow the funnel so that we can provide the best care or sufficient care to enough people? So it allowed me to see that difference and what it was like for the clinicians who practiced in military medicine versus civilian medicine, the level of frustration that they had, which was quite different. But in reality, most of the physicians that I worked with in the Army were at academic institutions across the US. They were in private institutions. They weren't primarily military physicians.
Just if you don't mind, and I'm sure any of the people listening here can already give me examples. But in terms of the constraints, like what did you see in terms of we have finite resources, we have to pick and choose? What were the most ubiquitous things that were pitted against each other, and what were the most damaging things that were pitted against each other for the sake of our discussion on moral injury?
Yeah. So there were really, the thing I have heard the most common complaint is scheduling. And I think the reason it's most frustrating for people is because it seems on the surface like it should be the easiest. Just let me control my schedule for the specialty that I do. I know how my workflow works best. I know how patients should move through my system. Let me smooth that out. Let me control how many patients I see an hour, what the time blocks are, what my initial visits are versus my follow-up visits. And consistently, what I hear from clinicians is that whatever scheduling system is used is immutable. They can't change it. They can't have control, and it is intensely frustrating. So that's probably the most common thing I hear. Call centers are second, where their patients call in and just get frustrated by the phone tree or by the runaround or by the fact that the call center is really trying to do their best, but they are hundreds of miles away and don't understand what the system is really like. So geographically, they don't understand the system. They don't understand how the offices work with each other or don't. So that's probably the second big issue. But I think the one that physicians struggle with the most is prior authorization. And the risk there is that patient care is going to suffer from the delays that get imposed by waiting for prior authorization. So as physicians, we go through anywhere from 7 years to more than a decade of training. We go through we pass multiple exams to get board certified in our specialty, which suggests that we know what the gold standard of care is. And yet, when we decide on a course of treatment, on a plan of care, we need an insurance company to approve it. And it may take weeks, may take days, weeks. Patients may have to go through 6 weeks of another kind of therapy. They may have to fail several different, in step therapy, they have to fail a series of other treatments before they can get the one that you recommend, all of which imposes delays. It adds up to patient suffering. It adds up to potentially worse outcomes. And it's all based on, again, narrowing the funnel.
I know at the Aspen Ethical Leadership Program in September, we'll talk about a lot of the, we'll diagnose the problem, we'll talk about a lot of practical alternatives or solutions or attempts that we can, put into practice or try to put into practice. But I want to take a step back and talk about just how you came up with the idea of moral injury today. Because I think that's also really interesting. I mean, there's a big difference between now in 2022, recognizing what it is and trying to figure out how to deal with it or how to ameliorate it or mitigate it. But I would love to know what happened in 2019 when you were like, oh, let's use the term moral injury. What was that? What was that light bulb?
Yeah, so that happened way before. So I had been, I'd had this kind of circuitous path in my own career, which I didn't have a name for. And in 2015, I read an article about a physician who died by suicide. And at that time, I was working for the Army, and I was often the only psychiatrist in the building. And literally 3 doors down was the neuropsych health program. And they were working on not only traumatic brain injury, but also on the crisis of death by suicide in the military and in veterans. And so I would often get pulled into their meetings just as sort of ground truth. And they didn't really need me, but they felt, they decided it was a good idea to have me. So I saw the extent to which the military was applying resources and thought leadership to ending suicide for veterans and active duty military. And when I read about this suicide in a physician, I thought, wait a minute, how does it compare? What are we doing for physicians? And I did the numbers literally on the back of an envelope, and physician suicides are only about 400 per year, which doesn't sound like a lot until you realize it's in a population of about 1 million. So it is a very small population. And it ended up being higher on the back of that envelope calculation. It was higher than what I was seeing in the military. So then I started thinking, all right, what are we doing? And I started looking at all of this literature on burnout. And so I started asking these colleagues that I worked with across the country who were struggling. And I said, okay, so you're burned out. And they're like, that I don't have better language for it, but it just doesn't hit right with me. I feel like I love what I do. I love taking care of my patients. It's everything that's all around it that really is the pebble. Those are the pebbles in my shoe. And I don't know what to do about it. I feel like it's just me not knowing how to do better. It's my own problem. But when I heard about it from dozens of clinicians, I started thinking, okay, this is not a them problem. This sounds more like the environment. And there was one day when I was weeding the garden and I was listening to NPR, and I heard about this concept of moral injury, transgressing deeply held moral beliefs and expectations, perpetrating, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And I thought, my gosh, this is it. We take this oath, whether it's spoken or unspoken, to take care of our patients as a priority always. And then we get out into we get out into practice and automatically have to start compromising that oath. That is a deeply painful thing. And it felt right. And I sort of, it was a test balloon for a couple of colleagues, and immediately they were like, oh, that's it. That is it. That's what I'm struggling with. And then it took us another year to write the article and get it published.
No, of course. Publishing is always takes forever. I wanna dig into the language for a sec, but there's something that you said that I want to ask you on. You looked at the physician who committed suicide. You looked at suicide rates among veterans. Do you think that what drew the light bulb, and then this speaks to the moral side of moral injury, was that both our professions, meaning that there's a set of expectations that you commit to uphold, and then when you can't uphold them, you set yourself up to fail almost, or you feel as if you've been set up to fail, which means is moral injury really a professional versus can anyone have, even if you're not part of a profession, have moral injury? And is the moral side therefore like a personal morality, or is it like a organizational or institutional ethos or ethics for moral injury to occur?
So I think it's yes and.
Can you want to tell me a little bit more when you say yes and, meaning it's the moral side means something different, or are you frozen?
Different in medicine and in the military is that we do take that oath. We are a profession. We have a covenant with society to provide something that society can't provide for itself. And so society, we promise to provide that service to society, and in return, society provides us with some things. And I think when we go into this knowing that it's a service on some level, and it is a privilege on some level. And when we have to break that covenant that has been so deeply ingrained for so many years, it's almost like losing a part of ourselves.
What does moral injury do that you couldn't use the term, trauma or not living, or even just a descriptive term in terms of, I feel that my work doesn't allow me to reach my professional potential? Like what does moral injury do that allows people to hang on to it and do the work, just linguistically to do the work of, yes, that's it. Like, as you said, your colleagues were able to then feel almost more comfortable when they had a term to describe how they felt.
So I really think that it gets at, so I had one person say to me, I was choosing between multiple different careers when they were in college. And my professor really wanted me to go and become a CIA analyst. I had the aptitude for it. I was good at it. They really wanted me to go there. And I kept getting pulled back to medicine because it called me to be a better person every day. And I think that's the piece that we forget, or that we kind of maybe get to start taking for granted as professionals, that there's a bigger reason why we went into this profession. And it's because we wanted to heal. We wanted to do good. We wanted to do an altruistic thing. And we're getting blocked from doing that by all of these constraints beyond our control that are not altruistic. And I think that really contaminates how we think about our profession.
Has your view of moral injury changed over the past, what is it? I mean, since 2015, so the past, 7 years or so. Meaning, like, while the term still works, sometimes we define it with more nuance or different changes, pre-pandemic, post-pandemic, to give like an obvious one, means that even if we're using the same term, it has somewhat of a refined or a different connotation today. Or was your 2015 light bulb, still working the same way that it had for the past 7 years?
So I think it is largely still the same, although, of course, thinking about it many hours a week for the last 7 years, it has shifted a little bit. What I find remarkable is I look back on the testimony that I gave at the end of February 2020 in New York City to the New York City Council about safety in New York City emergency rooms, specifically about moral injury. I could give the same testimony today and it would still be accurate. But I think the place where there is nuance is that I think that there's a relationship between moral injury and burnout that we didn't appreciate initially. That even though there are lots of roads to burnout, the highway is moral injury. And I think the other piece that we didn't appreciate, we appreciated to some degree, but has become much more clear after the pandemic, is that it is not just clinicians. Number one, it's all clinicians. We knew that going in. All clinicians are suffering from this, but also we've heard more and more that there are administrators who are suffering the same, and executives who are saying, I know what my people need, I can't get it for them. And that is deeply painful to me because I went into this wanting to support the clinicians who do the hard work. And I can't do it to the degree that I'd like to. And I'm watching people suffer and I can't stop it.
There's like one or two common misconceptions about moral injury that you've seen from people who aren't in healthcare or aren't in the military, or just, people who read it or read an article and they're like, yeah, I got it. Moral injury, like people suffer, something happened. They don't know what to do with it. Like what have you found that just, gets your, feathers up in terms of when people talk about moral injury, you're like, no, you don't get it. What have you seen that needs to be educated?
Well, so I think the one thing that I think challenges me more than anything is the concept that it's a religious experience, or that it's that somehow it is connected to religion. And I think for some people it is, but I also think that it doesn't have to be. Morality, religion doesn't have a corner on morality, nor is the solution to moral injury necessarily through a spiritual or religious path. I think that for some people, it certainly may be, but I think for a lot of people, the two are separate and the solutions are separate as well.
I would never have imagined that, Wendy. I really would, because maybe it's just where we're both from, but the way we're always talking about taking an oath, having professional expectations, having an ethos and a goal and values to lead your life professionally that are being hindered or obstructed or so forth. None of those are religious. It really just looks at moral of saying like, oh, where does morality come from? It's got to come from God, so therefore it's a God issue, as opposed to realize that people can have values that they uphold based on who they are, what they do, and what they care about. It's amazing to me that people would just throw morality into religion.
Yeah, and I think the other thing that I really worry a lot about is that the solutions will get boiled down to what I've heard more than once, which is atonement. And
I'm sorry, what was the word you used?
Atonement. Atoning for your actions. And I think that is it is an overly simplistic view of what the drivers of moral injury are. And I think, again, that risks holding the individuals responsible for the dysfunction of the system, which is a very dangerous place to go, especially right now, where individuals are feeling beleaguered on so many different levels. Healthcare workers are feeling beleaguered on so many levels. That holding them responsible for the dysfunction of the system is a surefire way to alienate them completely.
Carolyn asked a question in the Q&A in a way that was much more articulate than I ever would have asked. I was going to just ask you based on this was, Is everyone who suffers from moral injury a victim of moral injury, or can they also be a culprit of moral injury? Carolyn asks more about, just in a better way, what about agency? All right. I mean, if we say that people have an ethos or ethics or a morality that they want to uphold that keeps getting obstructed, I mean, no one in the profession is being coerced. They are making choices. So how does this speak to the individual versus the systemic or external factors in the etiology of moral injury?
So I think agency is a really important concept in the context of moral injury, and that one of the ways to avoid moral injury is to be able to stand up and speak out and push back. And although we can say that people have free choice, they can quit, they can walk away, they can do any number of things. In reality, it is not that black. It's not that black and white. If you leave a job abruptly, you can be blackballed. You may not have the nest egg if you have $500,000 of education debt. If you are the primary earner for your family, if you have a non-compete clause that requires you to uproot everybody and move 100 miles away, the ability to just up and quit, or when you have a specialty that requires a tertiary care center, you have limited options for where you move. So I do think agency is critical, and having people learn how to build their coalition that can stand up and speak out with them is critical.
Yeah, I mean, that's one of the things that we've actually spoken about this a lot. And it's one of the things that we actually emphasize greatly at the Aspen Ethical Leadership Program. You know, the whole concept of ought might imply can, but cannot implies ought not. So when we think of, oh, well, free will or agency means you can do whatever you want, it's not true. You know, Mary actually, Gentili says it best. She's like, look, there's a bell curve. There are a few sociopaths and there are a few moral saints, but the majority of us will only really be motivated to act if we can do so in a way that's both successful and not self-sacrificial. So part of that is recognizing, even if we may have agency in theory, the consequences may be too high for us to implement or to put that into practice. So we have to figure out where or what our agency or what our domain of agency actually is. Christopher asked a question, which since we've been talking about the different professions, is what are the similarities or differences did you see in the experience of moral injury between physicians and veterans? And I'll add to that, are the similarities really based in form? Meaning, like, even if they do or have different professions that do different things, is the form of injury in terms of the expectation obstruction or values, you know, acting on values hindrance the same, or are they completely different domains that moral injury is really just common symptomatically, let's say, but not necessarily by cause?
Yeah, so I think in veterans, what I've read about, what I've seen is that it's more often an egregious act where they're asked to do things that are egregious. It's an isolated incident or constrained to the combat environment. And so when they leave the combat environment, they're no longer subject to those potentially morally injurious events, or at least not as frequently or to the same degree. I think in medicine, it tends to be an accumulation of smaller insults over time. And I also think that it's that trying to address moral injury while you continue to be exposed to it, because the construct of healthcare isn't changing, is a much trickier approach. It's much trickier to do. But I think the transgression of your basic understanding of what your profession is and the covenant that your profession has with society is quite similar.
Just to go back to the beginning, did your experience as both a surgeon and a psychiatrist help like think about those issues in terms of like breaks and fractures or traumas that happen with like one large blunt, if you will, versus a series of smaller injuries that accumulate, and how those different treatments like are balanced by or not balanced by the cause of the injury. Like you can see how trauma over time versus a big trauma, like how it affects a person, both physically and mentally. Or is it something different in terms of when you look at the human body versus when you look at, organizational or professional traumas or injuries?
I think all of us who went into medicine expected to see those traumatic things.
Mhm.
I mean, I don't know any of us who didn't expect to work long hours and to see impossibly difficult things. What we didn't expect was to know what our patients needed and not be able to get it for them.
We have about like 15 minutes, so I want to push to something else, really in terms of like what you're working on now, what you see moving forward, because I think that's as interesting as what you've seen and what you've been working on. And also, if people want to talk more about the practical solutions of how to think about and change moral injury, they're always welcome to apply to the Aspen Ethical Leadership Program. How do you see moral injury affecting healthcare, like over the next few years? Like, if you had a crystal ball, or maybe you don't need a crystal ball, but someone like me who would need a crystal ball, what would I be looking for? What would I see in that crystal ball, in terms of if we don't fix moral injury, this is what the profession will look like?
Yeah, so I think we're seeing what my worst nightmare was 2 years ago when this started, which was that if we didn't pay attention to the well-being of our healthcare workforce, if we didn't give them slack in the system and put them as a priority, that they would start voting with their feet. And there are various estimates of what our gaps are, what our need for various health workers is. So 3 million lower wage workers, lesser skilled, not unskilled, but lesser skilled, 1 million nurses, and 140,000 physicians will need in the next 3 years. Those are the gaps that we're facing. And the first place, we're talking about replacing all these folks, but I would argue that the first thing we need to do is stop the hemorrhage out. We've lost 3 in 10 health workers over the past year to a year and a half. 1 in 5 physicians said they're going to be gone in 2 years. 1 in 3 nurses has said they'll be gone at the end of this year. That has to stop if we're going to have enough health workers to keep the system from imploding. And part of what we need to do in order to stop that is to start listening to what their challenges are. What are they objecting to? And let's start addressing those problems today, not when it's convenient, not when we've gotten back on our feet and we're back to business as usual, which wasn't working, by the way, before the pandemic.
Do you think the Fauci effect, and what I mean by that is, the increase in applicants to medical school and so forth, is just like a drop in the bucket, or do you think that people are seeing healthcare as, even if healthcare has been very difficult and people are leaving, people are still aspire to become healthcare heroes that are coming to medical school and excited to join the profession? that might have come off flippant, but you know what
No, I don't think it is flippant. I understand what you're saying. And I think it's encouraging to see that. At the same time, it is a drop in the bucket. It will be a decade before any of those people are out and practicing. That's a long time to wait.
Do you think that moral injury is really an American problem, and we could just import, healthcare professionals who haven't suffered moral injury yet, or I mean, this is obviously a leading question, or is moral injury a global problem which needs a wider lens to think about it?
It is, from what we're hearing, it is a global problem. We've heard from people in Mexico, in Spain, Germany. We're working with the UK, New Zealand, Australia. It is a global problem. There are the nuances of each system are slightly different, and so the drivers of moral injury in each of those systems is slightly different, but the experience is strikingly common.
And who needs to hear about moral injury for this next 3 to 5 years worst nightmare scenario to not happen? I mean, I doubt you need to tell clinicians. I feel like they already know what's going on. Or maybe you do need to speak to clinicians so they have a language to be able to articulate what the issue is, to be able to advocate for themselves more. I mean, I shouldn't answer for you. Who do you think? My problem. Who do you think should be the focus of these types of, or the participants of these types of conversations and discussions and so forth? Who are the stakeholders that need to be at the table?
So, patients. That means all of us, because at some point we will all be patients. And if you've been a patient recently, you'll know that healthcare is a very difficult thing to engage with. So patients need to know so that they can help advocate for better. But administrators and executives really need to understand how moral injury is different from burnout. I think it is arguably a nuanced term and concept. But in order to help their workforce feel like they're heard, if the workforce is saying, we're not burned out, or every single resilience program that gets put in front of them, they roll their eyes, maybe it's time to say, wow, I see you rolled your eyes. You know, when I took my kid out to a fancy restaurant at one point when he was 11, one of the wait staff came up to him and said, you're making some really interesting faces there. Can you, do you want something different? And I think maybe we need to start asking healthcare workers, what I'm serving you doesn't seem to be going down well. Do you want something different? And what might that be?
Okay, so then let me ask you this, and you may say this is a both and, but if you think it's a both and, then give me in terms of priorities. Healthcare is both a private good and a public good, right? So who are these people that you're saying, would you like something different? Is this a public charge, meaning like the government should be involved? Do you think that this is going to do better if it's a private charge, meaning, individual hospitals and senior leadership at hospitals need to recognize this for the sake of their own organizations and institutions? Like, where do you see efficacy?
You're right. It is a yes and. This is a crisis, and we need to intervene on multiple levels. So we need to intervene at an individual level to help people who are really suffering. We need to intervene in an organizational level to clear away, as somebody wrote about, the stupid stuff, to make it easier for our clinicians to do already incredibly difficult jobs. And we need to look on a societal level at, is it really what we want to have healthcare being a profit-making endeavor where we extract value from vulnerable patients? Is that really what we want? Or do we want to put guardrails on that? And how do we want to put those guardrails on? And who's the best where's the best place to put those guardrails?
Oh, well, so then let me ask you this, is it just a practical ramification question? You said that healthcare, moral injury in healthcare is a global problem. How is moral injury different in countries that have a different healthcare system than the US does, where let's say it's more public versus more private, whether it's private insurance or even distribution of healthcare goods. Like, so how, that's actually something that you could speak to in terms of if moral injury is greater in those areas that have more market flexibility versus more public regulation or public control. We kind of know a little bit about some of the factors of the inputs, right? So what have you been seeing? What have you seen globally?
So what it comes down to is that clinicians who are the experts in clinical care aren't allowed to control clinical care. So in places like the UK, where the NHS is in control largely, although they're increasingly becoming privatized and more US-like in many places, the government controls healthcare. So those constraints make it difficult for clinicians. In the US, it's often a revenue generating motive, whether it's in the nonprofit sector or in the for-profit sector. So hitting the numbers takes precedence over patient care. Not in every system, for sure, but in many systems. That's what we hear.
We could talk about this forever, but I promised myself
We can
that
in Aspen.
yes, we will in Aspen, and we'll not only talk about this, but we'll talk about how to both be aware, analyze, and act upon it. But I promised myself that I would not embarrass you, but definitely ask you about your new book, so you can plug that, as well as I know that you've been interviewed for a number of documentaries and have been consulted on a couple of documentaries on moral injury. I guess please tell me about that type of work, and also just like what's the point? Like, what is, and I don't mean that in a negative way, like what is the purpose of movies and more popular books and just getting the word out on moral injury in those types of media versus academic papers and conferences and stuff like that?
So I think, so we have a book coming out April 4th, 2023, which seems like forever, but in publishing time, that's actually relatively quick. It is a narrative nonfiction aimed at a general educated audience, because I think patients need to know. So often, I've heard so many times from people, friends, colleagues who aren't in medicine, that they have no idea what clinicians are really facing, because clinicians protect their patients. So they're the shield, and the clinicians throw themselves on the gears of medicine so that their patients don't have to suffer. And I really felt like somebody needed to speak for them, because it's also dangerous for most clinicians to speak for themselves. So the book, that's why the book. We have a podcast because during the pandemic, people didn't want to read anymore. They were reading all day, every day to try to catch up on the latest news about the virus. So we started the podcast because we're having great conversations. And so we wanted to get those out. And for a documentary, again, it's just to hit on a different channel, and people absorb information in very different ways. So we're trying every way we can think of to get the message out. And really the goal is to take care of the people who are taking care of patients. Somebody's got to have their back.
Yeah, well, like I would say that in any type of learning, the more avenues people can become aware and learn about an issue, the more interconnected it will be in their web of knowledge. I mean, I've seen some of the documentaries and that you've suggested, not to plug it, but I'm going to plug it. We are going to be watching a big section of All in My Power, the documentary that you recommended on the moral injury that occurred during the pandemic in New York. And what was it? In the beginning of the pandemic, like March, April time. I look forward to reading your book. I would say not to take the final word, but I'll take the final word to thank you. I want to thank you not only for the work that you're doing in general. I want to thank you for your help on the cases that we'll be discussing, the way we're thinking about it, the Aspen Ethical Leadership Program about moral injury. Personally, the work that I've been doing in moral injury has really been influenced by our conversations and how much I've learned from you. And I'm very excited both to continue to learn from you and just to see how far your work will make a change in healthcare, so that your worst nightmare of what happens in 5 years will not come to fruition.
Yeah.
So,
well, thank you, and I appreciate the opportunity to talk with you. This is a great hour.
It is, and offline, well, I'm sure we'll just continue to call each other and continue to speak to it. But at least we had a number of people who were interested get to hear at least how we're thinking about it and approaching it. So
right.
So for those of you who have been on for this past hour, thank you as well. If you want any more information on fixed moral injury, it's Wendy. It's fixedmoralinjury.org.
Correct.
And for information on the Aspen Ethical Leadership Program, you can check the chat for the link. And for those of you who are interested in coming to Aspen in September, we all look forward to seeing you. So thanks a lot and much appreciated.
Thank you.